Slide. Pseudoexfoliation syndrome. It is the most common cause of secondary open-angle glaucoma. And if the pseudoexfoliation syndrome is associated with glaucoma, then it is called pseudoexfoliation glaucoma. In most of the cases of pseudoexfoliation, there is mutation of single gene, that is LOXL1. It is commonly present in elderly people, that is more than 70 years of age, and his presentation is unilateral and more commonly seen in Scandinavian countries. Pathogenesis. In pseudoexfoliation, there is deposition of fibrillar material that blocks the conventional and uveoscleral outflow pathway, and that will cause the that will slow down or impede the outflow of aqueous humor, which will ultimately cause the raised intraocular pressure and glaucoma. Clinical features we can see, like in this picture, bullseye pattern, which is the typical sign that can be seen in the pseudoexfoliation syndrome. Here we can see the clear zones in between the fibrillar material. These clear zones are due to the scraping of the fibrillar material by the pupillary reaction. And this fibrillar material, they deposit almost in every tissues of the eye. And we can even see pupillary atrophy due to the exfoliation, and the transillumination defect in this pseudoexfoliation is around the pupil. There is poor pupil dilatation due to the exfoliation materials in the iris stroma, and we can even see phacodonosis due to the weak zonules. And in gonioscopy, there is a typical finding of, we can see a fine pigments in front of the Swalb's line, known as Sample-Lacey line, and we can even see the thick pigmented trabecular meshwork. Risk of glaucoma progression in pseudoexfoliation is 40% at 10 years. The diurnal fluctuation of the intraocular pressure is more than that of the primary open-angle glaucoma, and laser trabeculoplasty can be effective in treating this glaucoma. Pigment dispersion syndrome. It is characterized by the release of pigment granules from the iris pigment epithelium with deposition throughout the anterior segment. The age of onset is middle age, that is 20 to 50 years of age, usually bilateral. It's common in male than in female, and it's also seen commonly in myopic people. Pathogenesis. In pigment dispersion syndrome, there is a concave iris configuration, which causes the posterior bowing of the iris, and it results in the reverse pupillary block configuration. The zonular fibers robs the posterior iris pigment epithelium continuously that release the pigments throughout the anterior segment, that blocks the trabecular meshwork, and it raises the intraocular pressure. Clinical features. Typically, we will see in cornea, there will be vertical spindle in the corneal endothelium, known as Krukenberg spindle, and it results, the spindle shape results due to the convection current, aqueous convection current, and phagocytosis of the pigments by the corneal endothelium. In iris, we will see a transillumination defect, and it is different than that of pseudoexfoliation, because in this pigment dispersion syndrome, we see the transillumination defect on the mid-stroma of the iris. In lens, after dilatation, we can see the deposition of the pigments in the lens equator, also known as Jantemeyer ring. And we can even see the pigments in the anterior hyaloid. In the course of glaucoma, 15% of the patient with pigment dispersion syndrome, they progress to glaucoma. And IOP, from the history, we can even find out that the IOP rises after the exercise or pupillary dilatation due to the liberation of more pigments. Medical treatment is often successful in controlling the intraocular pressure. Laser trabeculoplasty is also effective, but the response is short-lived. And if the IOP is not controlled, filtering surgery is usually very successful. Laser peripheral iridotomy. Um, it is still controversial in case of pigment dispersion syndrome. Some people says that laser peripheral iridotomy, it minimizes the posterior bowing of the iris, and there will be and it also avoids the or reverse the reverse pupillary block situation. And in this picture we can see in the posterior PDS, in the pigment dispersion syndrome, we can see there is posterior bowing of the iris. This is controlled or treated after the PI. There, the posterior bowing and the reverse pupillary block is resolved. In secondary open angle glaucoma, lens-induced glaucoma is also lens-induced glaucoma is also common. The lens can cause both secondary angle closure glaucoma and uh, secondary open angle glaucoma. In secondary open angle glaucoma, phacolytic glaucoma, lens particle glaucoma, and phacoantigenic glaucoma is important. In in uh, phaco, in phacolytic glaucoma, it is seen more commonly in the elderly people with mature or hypermature cataract. In elderly people, the lens protein, it converts itself, it is changed into the high molecular weight lens protein. And these high molecular weight protein, they are released from the microscopic opening in the capsule, and these lens proteins, they block the trabecular meshwork, and the trabecular meshwork is also blocked by the macrophages that attempt to remove the lens protein. And these macrophages laden with high molecular weight lens protein and lens protein itself, inflammatory debris, these all obstruct the trabecular meshwork, which will give rise to raised intraocular pressure. Clinically, we will see worsening vision. Patient gives the history of poor vision, and there is history of the patient also complains of sudden onset of pain and redness. In signs, we will see conjunctival hyperemia. There is microcystic corneal edema. And in anterior chamber, we will see cells and flare, but there are no KPs. And we can even see the deposition of lens particle in the anterior chamber, which looks like hypopyon, but it is not hypopyon. And in lens, we will see the mature cataract with wrinkling of the anterior capsule, and there may be a presence of posterior synechia, which suggests the previous inflammation also. And treatment is we have to lower the intraocular pressure by medicine, and then lens extraction is the definitive treatment. Lens particle glaucoma mechanism, after some ocular surgery or post trauma, or even after the gag capsulotomy, there will be retention of the lens material in the eye. These materials can obstruct the trabecular meshwork and gives rise to raised intraocular pressure. Clinically, we will see microcystic corneal edema. There is signs of inflammation, moderate reaction in the anterior chamber. We can even see the cortical matters in the anterior chamber. There may be presence of posterior synechia and peripheral anterior synechia and raised intraocular pressure. Treatment is we have to reduce the intraocular pressure by medicine, anti-glaucoma medicine, mediatrics to release the ciliary spasms, then topical steroids to control the inflammation. And if the intraocular pressure is not controlled with medicine, then we have to surgically remove the lens material from the AC. Phacoantigenic glaucoma, also known as phacoanaphylaxis glaucoma. It is a rare condition. In this condition, the patient is sensitized to its own lens particle, and there is granulomatous inflammation, and inflammation usually occurs after the surgery or the penetrating trauma. Clinically, we will see KPs on the corneal endothelium. In anterior chamber, there is moderate reaction, residual lens material. There is presence of posterior synechia and peripheral anterior synechia, and there is also presence of low grade of vitritis. Treatment is anti-glaucoma medication to decrease the intraocular pressure, steroids to control the inflammation, and residual lens material. It has to be removed surgically after the control of inflammation. Intraocular tumors, they also cause secondary open angle glaucoma, and they are responsible for unilateral glaucoma. The IAP elevation in secondary open angle glaucoma due to tumors can be caused by several mechanisms. The most important and common is the direct tumor invasion to the anterior chamber angle, or it can also cause the raised intraocular pressure and angle closure glaucoma due by the ciliary rotation of the ciliary body, and anterior displacement of the lens iris diaphragm. Uh, there may be raised intraocular pressure and glaucoma due to intraocular hemorrhages, neovascularization of the angle, and deposition of the tumor cells or inflammatory cells debris in the trabecular meshwork. Ocular inflammation and secondary glaucoma. Now, many ocular inflammations are also responsible for the secondary open angle glaucoma. The mechanism is, it may be due to the edema of the trabecular meshwork, it may be due to the endothelial cell dysfunction, fibrin and inflammatory cells blocking the outflow through the trabecular meshwork or the Slime's canal, and the corticosteroids that are used in the inflammation also increase the intraocular pressure by reducing the outflow from the trabecular meshwork, peripheral anterior synechia blocking the outflow, and prostaglandins that causes the breakdown of the blood aqueous barrier. Open angle glaucoma that are common in these uveitis. These are the list. In the ocular inflammation induced glaucoma, clinical features. In clinical features, we will see raised intraocular pressure. There is cells and flare in the anterior chamber, presence of keratic precipitates, and in gonioscopy, we will see trabecular meshwork precipitates. Treatment is corticosteroids to control the inflammation, but it can increase the outflow resistance. IOP lowering agents are used to control the intraocular pressure, and in IOP lowering agents, prostaglandin analogs may exacerbate the inflammation. But in some patients, they may have low intraocular pressure due to the prostaglandin-mediated increased uveoscleral outflow. Glaucomatocyclitic crisis, also known as Posner-Scotsman syndrome. It was described by Posner and Scotsman in 1948. This is a recurrent condition, usually unilateral, and affects the middle-aged people. And many viral infections are also, viral associations are also seen in the patients with Posner-Scotsman syndrome. Symptoms: patient will complain of unilateral blurred vision and ocular pain. In signs, we will see high intraocular pressure, about around 40 to 50 millimeter of mercury. There is presence of corneal edema. There is mild inflammation and presence of few small KPs. And in gonioscopy, we can see KPs on the trabecular meshwork also. Treatment: we have to lower the intraocular pressure with topical and oral hypotensive medication, steroids to control the inflammation, and we can even use topical or oral anti-inflammatory drugs. And in some patients, if there is long-standing raised intraocular pressure with optic nerve damage, then we have to go for filtering surgery. Fuchs uveitis syndrome. It is idiopathic and unilateral, and there is low grade of uveitis, chronic low grade of uveitis, and is commonly seen in young to middle-aged people. There is no sex or age, race predilection. It is also it may be associated with certain viral infections. Clinically, we will see raised intraocular pressure. In the cornea, there will be presence of small stellate KPs. Anterior chamber will show low grade of inflammation. There is iris heterochromia, loss of pigment in the iris. In lens, there will be posterior subcapsular cataract. but eyes are not eye is not red or hyperemic. In gonioscopy, in gonioscopy, we will see fine vessels in the trabecular meshwork, but but these vessels are very fragile, but they are not associated with membrane, so it does not cause the angle closure. And Amsler sign is the sign of sudden bleeding in the anterior chamber when it is during the surgery, when we enter the anterior chamber or after the trauma. Glaucoma occurs about 15% of the patients with Fuchs heterochromic iridocyclitis. Treatment is ocular hypotensive medication to control the IOP and corticosteroids. And sometimes, if the condition is long-standing, then we have to uh, go for filtration surgery also. Another cause of secondary open angle glaucoma is elevated episcleral venous pressure. Normal episcleral venous pressure is 6 to 9 millimeter of mercury. This is the table showing the causes of elevated episcleral venous pressure. Clinically, there will be chronic red eye. There is no ocular discomfort or any discharge. Episcleral veins are tortuous. We will see a large tortuous dilated vessels. In gonioscopy, we can see blood in the slime scanner, like in this picture, second picture. And in case of sudden, if the episcleral venous pressure is due to the sudden or severe carotid cavernous fistula, then we may see the proptosis and other neurological signs. In this case, we have to do the thorough investigations like MRI and MRA to rule out the vascular malformations, angiography with neuroradiologic intervention, and in treatment, topical or ocular hypotensive medication to control intraocular pressure. But the pressure control is very difficult. We may need glaucoma filtration surgery, and there is always risk of ciliochoroidal effusion and suprachoroidal hemorrhage. Laser trabeculoplasty is not effective. Trauma and surgery. Certain trauma and surgery, penetrating, non-penetrating blunt trauma, to the eye may cause the secondary open angle glaucoma due to inflammation, hyphema, angle recession, or lens subluxation. Among them, traumatic hyphema, we can see raised intraocular pressure and secondary glaucoma with traumatic hyphema. Etiology is there is obstruction of the trabecular meshwork with red blood cells, inflammatory cells, cell debris, and fibrin. And it may be due to the direct injury to the trabecular meshwork, which will impede the aqueous outflow. And increased risk of elevated intraocular pressure in traumatic hyphema is seen in case of recurrent hemorrhage or rebleeding that usually occurs within 3 to 7 days after the initial hyphema, and frequency of rebleeding is 5 to 10%. And if the size of hyphema is large, then it can also rise the intraocular pressure. Patients with sickle cell hemoglobinopathies can show very raised intraocular pressure even with small amount of hyphema, because the low pH of the aqueous, it causes the sickling of the red blood cells and makes it very rigid. And these rigid red blood cells are very difficult to pass through the trabecular meshwork. They are trapped in the trabecular meshwork, and they raise the raises the intraocular pressure. And due to the compromised microvascular perfusion of the sickled red blood cells, they are prone to develop anterior ischemic optic neuropathy as well as ventral retinal artery occlusion. In gonioscopy, we will see subtle hyphema, and we can even see corneal blood staining. In this picture, we can see there is iridodialysis and corneal blood staining. Management. We must ask the patient to limit the physical activity and lie down with head elevation. We can use cycloplasics to control the ciliary spasm. We can give anti-inflammatory drops. Then we have to control intraocular pressure by ocular hypotensive medicines. And while giving carbonic anhydrase inhibitors and hyperosmotic agents, we have to be very careful in patients with sickle cell disease because it lowers the pH and increases the sickling tendency. Surgical intervention is needed in most of the cases of hyphema, and indication for AC irrigation is if there is vision obstruction by hyphema or corneal blood staining in case of children, if there is total hyphema, and the patients with sickle cell disease. We may need filtering surgery with anterior chamber washout if the IOP is uncontrolled. Then comes hemolytic and ghost cell glaucoma. It develops usually after the vitreous hemorrhage. In pathophysiology, when there is vitreous hemorrhage, the RBC, it gains access to the anterior chamber through the disrupted hyaloid phase. And the hemoglobin-laden macrophages and the degenerated red blood cells, also known as ghost cells, they obstruct the trabecular meshwork and rise the intraocular pressure. Clinically, patient gives the history of recurrent vitreous hemorrhage. There is corneal edema due to raised intraocular pressure, elevated intraocular pressure. In anterior chamber, we can see red tinged cells or the ghost cells. These are the khaki colored cells. And in gonioscopy, we will see the ghost cells mostly in the inferior angle. Management is IOP usually comes to normal after the vitreous hemorrhage is resolved. We may need to give aquasuppressants to lower the IOP, but if the IOP is not controlled, then we may have to do anterior chamber irrigation, pars plana vitrectomy, and sometimes incisional glaucoma surgery. Traumatic or angle recession glaucoma. Due to trauma, blunt trauma, there is angle recession, and in angle recession glaucoma, it usually chronic and usually it is unilateral. And angle recession glaucoma after the trauma occurs due to the tear between the longitudinal and the circular muscles of the ciliary body. And the glaucoma, it may develop immediately after the trauma or months to years after the trauma. Clinically, patient gives the history of trauma in the past. Patient may present with elevated intraocular pressure in the affected eye. We may see the signs of previous trauma like corneal scar, iris injury, anterior subcapsular cataract, and phacodonosis. And when we do the gonioscopy, we will see the typical signs of the angle recession. We will see there is a widening of the ciliary body band. There is absent or torn iris processes. Scleral spur may be visible. There will be irregular and dark pigmentation in the angle, and peripheral and anterior synechiae can be seen at the border of the recession. In this first picture, we can see there is deepened angle recess due to the trauma. And in the second picture, the arrows are pointed towards the torn iris processes. Course of glaucoma in angle recession. The more the recession, the increase the risk of glaucoma. The risk of developing glaucoma, it decreases appreciably after several years, but it is still present even after the 25 years or more after the injury. Treatment is lowering the intraocular pressure by aquasuppressants, prostaglandin, analogs, and if it's not responding to the medical therapy, then we have to go for incisional surgery. Steroid-induced glaucoma. The risk factors with steroid-induced open-angle glaucoma is primary. The risk factors are patients with primary open-angle glaucoma. They are 95% susceptible to steroid-induced glaucoma. People with first degree relative with POAG, they are more susceptible to steroid-induced glaucoma. Patients who are very young, less than 6 years of age, people having connective tissue diseases, type 1 diabetes mellitus, and myopia, they are at the risk. In steroid-induced glaucoma, management will be to discontinue the corticosteroids. In many patients, it works, but 25% may require topical medications to control the intraocular pressure, and 1 to 2% of people may require incisional surgery. Now, my second topic is primary angle closure glaucoma. Primary angle closure, it refers to the mechanical blockage of the trabecular meshwork by the peripheral iris, that is iridotrabecular contact, or due to the formation of the synechia, peripheral anterior synechia. Angle closure refers to the presence of peripheral anterior synechia, ocular hypertension associated with angle closure, acute primary angle closure, or glaucomatous optic neuropathy. There are two main categories, primary angle closure and secondary angle closure. Primary angle closure, this is due to anatomic predispositions, and secondary angle closure due to the various conditions in the eye. European Glaucoma Society has classified angle closure into primary angle closure suspect, in which there is more than 180 degrees to 180 degrees or more iridotrabecular contact, but there is no damage to the trabecular meshwork or optic nerve. Then another is primary angle closure, in which there is 180 to 180 degrees or more iridotrabecular contact with elevated intraocular pressure or presence of pus, but there is no optic nerve damage. And primary angle closure glaucoma, where there is primary angle closure with glaucomatous optic neuropathy. Prevalence, it is estimated that angle closure glaucoma will reach 32 million in 2040, more common in female and in certain ethnic groups. Prevalence rate is very low in European and African population. Angle closure glaucoma is accounted for over 90% of blindness due to glaucoma in Chinese population. Pathogenesis, the apposition or the addition of the peripheral iris to the trabecular meshwork can be of two types. It may be transient, the closure may be transient or intermittent, like appositional, or it may be the closure may be permanent, that is synechial. Pupillary block is a major mechanism in the secondary angle closure glaucoma. Primary angle closure, and pupillary block is maximum when the pupil is mid-dilated position, in the mid-dilated position. There are certain anatomical factors like lens iris interface, iris thickness, area of the iris, volume of the iris, small anterior chamber dimensions including anterior chamber depth, width, anterior chamber area, and volume. These are also the risk factors for angle closure. A plateau iris and iris induced. It is seen that about 1/3 of the patients with primary angle closure, they have plateau iris configuration. In this picture, we can see there is large anteriorly positioned ciliary processes that is blocking the angles. Risk factors for primary angle closure are race and ethnicity. It is seen that in Japanese individuals And in Chinese population, the prevalence is very high. And another risk factor is the ocular biometrics. Uh, the patients with the people and the angle closures are associated with shallow anterior chamber, thick lens, increased anterior curvature of the lens, short axial length, small corneal diameter and radius. And anterior segment imaging shows increased iris thickness and area and greater lens vault. And anterior chamber depth of less than 2.5 millimeter predisposes to patients to angle closure. Age, the prevalence of angle closure increases with the age, that is each decade after 40 years of age. In sex, it is 2 to 4 times more common in women than in men. Maybe it is because of the anatomical variations. Short axial length and small anterior segment in females. Family history, the it is increased in first degree relatives of affected individuals. In white, among the white, it is 1 to 12%, and among the Chinese population, the risk of developing angle closure with positive family history is 6 times higher. Refractive error, most of the patients with angle closure, they are hyperopic, but we can also see angle closure in some myopic patient. Uh, so it may be, so we have to rule out any secondary causes of angle closure in the patients with myopia. Primary angle closure spectrum, there is a primary angle closure suspect in which the primary angle closure suspect eyes are at risk of developing the angle closure. In the picture, we can see the angles are closed when the lights off because of the crowding of the pupil is dilated and crowding of the iris in the angles. And when the lights are on in the same eye, the angles are open because the pupil constricts and the iris is pushed away from the angles. Management is peripheral iridotomy. Primary angle closure, it is defined with the shallow AC primary angle closure suspect with raised intraocular pressure. And patient may be asymptomatic for, it is a chronic form, and patient may be asymptomatic, and this is the most common form of the angle closure. Management is laser peripheral iridotomy, IOP lowering agents, but the Eagle Eye study, they have suggested that in primary angle closure cases with IOP more than 30 millimeter of mercury, lensectomy is preferred. Primary angle closure glaucoma, it is the form of angle closure disease where there is primary angle closure along with optic nerve damage and corresponding visual field loss. It is the major cause of blindness in Asia. Management is laser peripheral iridotomy, medical treatment, then cataract surgery alone, or sometimes we have to combine the cataract surgery with trabeculectomy. Angle closure can be symptomatic and it can be acute or subacute. In subacute, there will be blurred vision, colored halos, and mild pain that caused by elevated intraocular pressure. The visual symptoms resolve spontaneously, and in between the episodes, there will be normal intraocular pressure. The correct diagnosis can be made only by gonioscopy and high index of suspicion. The management is of subacute primary angle closure glaucoma is TDAC. Acute primary angle closure. In acute form, there is sudden blockage of the trabecular meshwork by the iris, and it is manifested by ocular pain, headache, blurred vision, rainbow haloed, colored halos around the lights, and patient may be associated with complaint of nausea and vomiting. Signs of acute angle closure is high IOP, mid-dilated, sluggish, and irregularly reacting pupil, corneal epithelial edema, congested episcleral and conjunctival blood vessels, shallow peripheral anterior chamber, mild amount of aqueous flare and cells. Definitive diagnosis is done by gonioscopy. We can do dynamic gonioscopy with indentation of the central cornea that will help the help you reverse trabecular iris trabecular mesh blockage. Gonioscopy in the fellow eye is also very important in case of um, in the patients who presents with sudden acute angle closure. And if there is presence of deep angle in the fellow eye, then we have to search for the secondary topic of secondary angle. And management of acute angle closure is laser peripheral iridotomy. If the acute primary angle closure is mild, it may be broken by the cholinergic agents like pilocarpine. Other topical and oral or intravenous um, medicines can be given to decrease the intraocular pressure. If needed, we can also use hyperosmotic uh, agents intravenously or orally. Then lens extraction should be performed once the attack is broken and once the cornea is clear. Uh, it and in these patients, we have to do the PI in the fellow eye. We must do. Tattoo iris. It refers to the typical configuration of the anterior chamber angle and may result in the angle closure disease. It's commonly seen in the young people. In tattoo iris, central anterior chamber depth is normal, but the peripheral depth is shallow. And then this can be confirmed by the gonioscopy, where we will see the double hump sign. Uh, Management in plateau iris, laser iridotomy to remove the uh, pupillary block, or lensectomy if the cataract is present. Plateau iris syndrome is the most common reason for a persistently narrow or occludable angle even after the laser peripheral iridotomy or the cataract surgery. And laser peripheral iridoplasty um, is more useful than LPI. Now, the last topic is secondary angle closure glaucoma. Uh, Secondary angle closure glaucoma can be divided in two types, pupillary block and non-pupillary block. In non-pupillary block, it can be due to the pushing mechanism that pushes the iris forward from behind, or due to the pulling mechanism that pulls the iris forward into contact with the trabecular meshwork, or it can be of combined pushing and pulling mechanism. Secondary angle closure with pupillary block. Uh, we will see this commonly in lens-induced angle closure. And in lens-induced, it may be due to the phacomorphic glaucoma, like ectopia lentis, microspherophakia, or in aphakic or pseudophakic angle closure. In phacomorphic glaucoma, this is caused by the multi-factors, and the people with narrow angles are more susceptible to the phacomorphic glaucoma. And it occurs due to the increased thickness or cataractous lens. And it is precipitated by the marked swelling, that is intumescent lens, and it causes the pupillary block. And treatment of phacomorphic glaucoma is cataract surgery. And in most of the cases, if the condition is not long-standing, the patient may benefit from the surgery. An iridotomy is not necessary in many cases. Um, in some cases, uh, cholinergic agents are also used, but it has no role or very poor role in the treatment of the phacomorphic glaucoma. Ectopia lentis. Uh, this is the condition in where there is the displacement of crystalline lens from its normal anatomical position. Uh, the forward displacement causes the pupillary block, which gives rise to iris bombae, shallowing of the anterior chamber, and secondary angle closure. These are the common causes of the ectopia lentis. In the first picture, we can see there is complete dislocation of the lens. The lens is in the anterior chamber, and in second picture, we can see there is subluxation of the lens. Treatment is lens extraction. It usually restores the vision and reduces the risk of recurrent pupillary block and pus formation. Microspherophakia. This is the congenital disorder in which the lens has a spherical or globular shape. It may cause ectopia lentis and subsequent pupillary block that results in the angle closure. It is often familial and in may occur as an isolated condition or as a part of Weil-Marchesani syndrome or the Marfan syndrome. Treatment of microspherophakia is we use cycloplasic agents that tightens the zonules, flatten the iris, flattens the lens, and pulls it posteriorly, breaking the pupillary block. Aphakic or pseudophakic angle closure. In case of aphakic and pseudophakic people, the vitreous can block the pupil or the iridotomy side that results in iris bombae, anterior chamber shallowing, and angle closure. Topical IOP lowering agents and hyperosmotic agents are given to control the intraocular pressure. We may need laser iridotomies, more than one. Mediatic and cycloplasmic agents may restore the aqueous flow through the pupil. Secondary angle closure without pupillary block, two mechanisms as I have already explained, pulling mechanism and the pushing mechanism. Pulling mechanism caused by the inflammatory, hemorrhagic, cellular or the vascular membrane or bands that leads to the pus formation. And in pushing mechanism, there is forward displacement of the lens iris interface accompanied by the swelling and anterior rotation of the ciliary body. These are the this is the table that shows the different mechanisms responsible for anterior pulling and posterior pushing mechanisms. A neovascular glaucoma, uh, it is characterized by anterior segment neovascularization along with the fibrovascular membrane on the surface of the iris, pupillary margin, and trabecular meshwork, and it is caused um, these disorders. It usually involves the retinal or ocular ischemia or ocular inflammation, and it is most commonly seen in diabetic retinopathy, CRVO, BRVO, and other ocular ischemic syndrome. In this picture, we can see there are fine vessels on the iris stroma. This is the table showing the different disorders that leads to neovascularization in the angle. Main pathophysiology is secretion of angiogenic factors, especially uh, VEGF from the ischemic retinal tissue. These angiogenic factors, they diffuse into the anterior chamber and it causes neovascularization in the iris and angle. And when uh, these new vessels are associated with fibrovascular membrane, and when these contract, they develop the pus, formation of the pus, and causes the angle closure. In this picture, we can see there is complete closure of the angle. Clinically, there will be acute rise of intraocular pressure with reduced vision, ocular pain, conjunctival hyperemia, and corneal edema. The neovascularization, it begins at the pupillary margin and then it extends radially over the iris, then invade the angle. Treatment is pan-retinal photocoagulation. It is the definitive treatment if the ocular media is clear. Then we can also give intravitreal anti-VEGF injections to reduce the neovascularization. Then in medical management, we have to give uh, oral and topical medications to lower the intraocular pressure. And in many cases, we may need incisional glaucoma surgery, but it is advised to do the incisional surgery after the PRP or the anti-VEGF injections. Some patients may need glaucoma drainage device implantation. And if the prognosis is very poor, cyclophotocoagulation is done for the to reduce the intraocular pressure. This is the picture where we can see in the first picture, there is diffuse iris neovascularization, and the same eye after the anti-VEGF injection, the neovascularization reduces markedly. So it is advised to do the surgery after the laser after the PRP or after injection, VEGF anti-VEGF injection. ICE syndrome, iridocorneal endothelial syndrome. This also causes the secondary angle closure glaucoma, and these are the group of the disorders in which there is endothelial cells, abnormal corneal endothelial cells that act as the epithelial cell. There are three clinical variants. One is Sandler syndrome, essential iris atrophy, and Cogan-Reese syndrome. Sandler syndrome is the most common type, accounting 50% of the ICE syndrome. It is usually unilateral. It's more common in women. Age of presentation is 20 to 50 years. There is no ocular or systemic association. There is no inheritance pattern, and viral etiology is also seen. Clinically, there will be decreased vision, elevated intraocular pressure, corneal edema, bronze-beaten appearance of the corneal endothelium, and abnormal iris appearance. And it's a picture of Gonio photograph where we can see there is formation of pus. Essential iris atrophy, it is the severe progressive iris atrophy with the formation of the hole, giving rise to polychoria, then heterochromia, correctopia, and even ectropion uvea. The first picture is the essential iris atrophy. And Sandler syndrome, this is most common type of the ICE syndrome, and there is minimal iris atrophy and correctopia, and we can see corneal and angle findings are predominant. In Cogan-Reese syndrome, there is diffuse pigmented lesion on the anterior iris surface. Therapy is directed towards the corneal edema and elevated intraocular pressure. We can use IOP lowering agents and hypotonic saline. If the medical therapy fails, then we have to go for incisional glaucoma surgery. Epithelial and fibrous ingrowth, when it occurs when the epithelium, fibroblast, or both of them invade the anterior chamber through a defect in the wound site. The risk factors are prolonged inflammation in the eye, if there is wound dehiscence, if there is delayed wound closure after the surgery, or even if there is descemet membrane tear. Epithelial ingrowth, there is a fine grayish sheet-like membrane on the trabecular meshwork, ciliary body, iris, and posterior surface of the cornea. And the ingrowth, it consists of non-keratinized stratified squamous epithelium. Whereas in fibrous, the second picture is showing the fibrous ingrowth, and it is very thick, gray, white, vascular membrane that is in the retrocorneal, that is present in the posterior surface of the cornea. The ingrowth often involves the angle that results in the pus formation and disrupt the trabecular meshwork, and it even causes the ectropion uvea. Conditions associated with pushing mechanism. Tumors, they are responsible for the pushing mechanism and causing the secondary angle closure. Posterior segment tumors, they tend to shift the lens iris interface forward as the tumor enlarges. It also breaks down the blood aqueous barrier, and it causes the inflammation. From the inflammation, that can result in the posterior synechia formation. And these tumors can also cause the neovascularization of the anterior segment, leading to the angle closures. Malignant glaucoma. This is rare but potentially devastating form of glaucoma that usually presents following ocular surgery in the patients with history of angle closure. The mechanism is it is thought that it results from the anterior rotation of the ciliary body and posterior misdirection of the aqueous in association with relative block to forward the aqueous movement at the level of the lens equator, vitreous phase, and ciliary processes. Uh, in malignant glaucoma, there will be uniform flattening of both the central and the peripheral AC, and there is anterior displacement of the lens or IOL or the vitreous phase. And there is marked asymmetry between the finding of the anterior chamber finding of the affected eye and fellow eye. In this picture, we can see there is the shallowing of the anterior chamber, uniform shallowing of the anterior chamber, both in the center and the periphery. A medical management is cycloplegic therapy, aqueous suppressants, hyperosmotic agents. Then we can do laser treatment like ND-YAG laser to disrupt the anterior vitreous in aphakic and pseudophakic eyes, laser iridotomy. And surgical treatment is the definitive treatment. We can do pars plana vitrectomy with anterior hyaloid zonulectomy combined with iridectomy and anterior chamber deepening. UVL and ciliary body effusions, collection of fluid or blood in the potential space between the uvea and sclera. It can cause the secondary angle closure. The suprachoroidal or supraciliary mass effect may result in the secondary angle closure that related to the forward displacement of the lens iris interface. These are the list of the causes that can cause the uveal and ciliary body effusions. Some vitreoretinal surgery can also lead to secondary angle closure. That is commonly seen in the sclerobuccal procedures, which causes the shallowing of the anterior chamber and is accompanied with choroidal effusion and anterior rotation of the ciliary body, leading to the flattening of the peripheral iris. Pars plana vitrectomy with in some after some vitrectomy and injection vitrectomy and followed by injection of air or long acting gases or silicone oil can lead to angle closure. Medical therapy is cycloplasics, anti-inflammatory, aqueous suppressants, hyperosmotic agents to decrease the intraocular pressure. And we can also do laser iridotomy, drainage of the suprachoroidal fluid, or release of the scleral bands, removal of the silicone oil or gas can be done. And if the intraocular pressure is persistently high, then we can go for glaucoma incisional surgery. Nanophthalmus, it is also responsible for secondary angle closure glaucomas. In nanophthalmic people, they have the axial length, short eye with the axial length less than 20 millimeter of mercury, with small corneal diameter and the most of the patients are high hyperopics, and when these patients are susceptible to angle closure at early age, it can be treated medically or with laser iridotomy, iridoplasty. They have thickened sclera that impede the drainage from the vortex veins and cause the choroidal effusion that will cause the angle closure. Drug-induced secondary angle closure glaucoma. There are certain drugs which causes secondary angle closure glaucoma. Topiramate is one of the drug that causes secondary angle closure glaucoma. It causes the acute myopic shift and acute bilateral angle closure. And the symptoms occurs within 1 month after starting the drug. There are certain other drugs that can also induce the angle closure. Clinically, we will see there is sudden bilateral loss of vision, decreased vision with myopia, bilateral ocular pain, headache, There is uniform shallowing of the anterior chamber and anterior displacement of the lens iris and lens. There is microcystic corneal edema. IOP is usually very high, 40 to 70 mm of mercury, closed anterior chamber angle, and ciliochoroidal effusion. This is the ultra. Can you, this is and in this picture we can see uh, the first picture. There is the asterisk sign shows the shallowing of the anterior chamber, and the arrows are showing the choroidal effusions. Treatment is we have to discontinue the medication immediately, and we can give echo suppressants, cycloplasics, systemic corticosteroids. Secondary angle closure usually resolves within 24 to 48 hours after stopping the drops. And myopia resolves within 1 to 2 weeks after discontinuing the medicine. Certain ocular inflammations can also cause secondary angle closure. The fibrin and increased aqueous protein causes the formation of posterior synechiae that can lead to secluded pupil, iris bombae, and secondary angle closure. Peripheral iris edema and organization of inflammatory debris in the angle can also lead to formation of pus leading to angle closure. Ischemia secondary to inflammation may cause um, um, iris vessels and neovascular glaucoma. Uveal effusion and subsequent anterior rotation of the ciliary body can cause shallowing of the AC and angle closure. Significant posterior uveitis can cause massive exudative retinal detachment or choroidal effusions that push the lens iris interface forward, resulting in the angle closure. So in this picture, we can see there is a fibrovascular, there is a membrane in the AC in front of the pupil with the seclusio pupil. There is formation of the pus and seclusio pupil in the third picture also. With this, I conclude my presentation. Thank you very much for listening.
Thank you very much, Dr. Pratibha. That was fantastic. Really, really excellent. We are going to have now Dr. Indira to talk to us about chapters 11 and 12, glaucoma in children and adolescents, as well as medical management.
Good evening, everyone. I'm Indira Paudyal from Tilganga Institute of Ophthalmology. I'll be talking on two chapters, chapter 11 and 12. So chapter 11, glaucoma in children and adolescents. So pediatric glaucoma, at least two of the following criteria are required for the diagnosis. That is intraocular pressure of more than 21 millimeter. And in cornea, there's HAPS striae and optic nerve. There can be cupping, and there can be progressive myopia and visual field defect. So any of the two can be diagnostic. And pediatric glaucoma suspect, at least one of the following criteria required for diagnosis, which is IOP more than 21 in separate occasion and suspicious or increased cup disc ratio or increased corneal diameter or axial length in eyes with normal IOP. So this table gives a definition of pediatric glaucoma and glaucoma suspect, depending on the findings, which I've already said. And now when we come to the classification of pediatric glaucoma, it can be divided into two main, primary pediatric glaucoma and secondary. So primary congenital glaucoma, in this neonate or newborn onset, which depends on the age 0 to 1 month. Infantile is 1 to 24 months, and late onset is more than 24 months, which is 1 year, and juvenile open angle glaucoma, it's up to 40 years. So when we come to the secondary glaucoma, then it is again divided into glaucoma associated with non-acquired ocular anomalies, glaucoma associated with non-acquired systemic disease, and glaucoma associated with acquired condition, and glaucoma following cataract surgery. Features of primary pediatric glaucoma: isolated angle anomalies that may present with mild congenital iris anomalies. It meets glaucoma definition, usually with ocular enlargement, spontaneously arrested cases with normal IOP but typical signs of PCG, and juvenile open angle glaucoma. There may not be any congenital anomalies or syndromes, and open angle, normal appearance, and meets the glaucoma definition. So PCG, there is isolated angle anomalies, and it meets glaucoma definition, usually with ocular enlargement, and we can see spontaneously arrested cases with normal IOP, but typical signs of primary congenital glaucoma. And in primary congenital glaucoma, genetic, it's mostly sporadic, and 10 to 40% are autosomal inheritance. So in this, 70% are bilateral, and it's more common in males, which is 65%, and it's mostly 75%, which is mostly diagnosed within the first year of life. And coming to the pathogenesis, it's uncertain clinically, though, to result from arrested mutation of angle structures and anterior chamber dysgenesis. So the pathogenesis is unclear. And in primary congenital glaucoma, here you can see in the above picture of the child. So in the left, you can see an enlarged eyeball, and in the inferior, you can see half striae on the cornea. So clinically, classic triad of epiphora, photophobia, blepharospasm, increased corneal diameter, enlarged globe, corneal edema, and corneal opacification are commonly seen. So this table, it shows the differential diagnosis for symptoms and signs of primary congenital glaucoma. So with epiphora, there can be different differential diagnosis like nasolacrimal duct obstruction, keratitis, and rest we can see here. And in condition associated with corneal clouding, there can be history of birth trauma like forceps deliveries, which are not common these days, and metabolic disorders like mucopolysaccharidosis and many other conditions. And conditions associated with optic nerve abnormalities, it can be differentiated with optic nerve pit or atrophy or physiological cupping, usually when there is a large optic nerve head. And coming to the treatment, examination under anesthesia and surgical intervention is the definitive treatment. And prognosis, when this glaucoma occurs in early age, within 1 to 3 months, it's good prognosis. Poor prognosis if it's diagnosed after age 1, when the corneal diameter is more than 14 millimeter at diagnosis, severe dysgenesis, and more than 50% of newborn with primary congenital glaucoma progress to legal blindness. So recognizing the glaucoma on time and coming to presentation to the hospital on time, they are also a good prognostic factor for them, since 50% of the newborn, they can go blind. Juvenile open angle glaucoma. So in JOAG, usually the angles appear normal. There is elevated IOP, no ocular enlargement, no congenital or ocular anomalies or other syndromes. And treatment is medical therapy and incisional glaucoma surgery, which is trabeculectomy or other minimally invasive glaucoma surgeries. So the features of secondary pediatric glaucoma. Here it can be classified, which I have already said before. And features of glaucoma associated with non-acquired anomalies, like conditions with predominantly ocular anomalies present at birth that might be associated with systemic signs, like example, Axenfeld-Rieger anomaly, Peters, congenital iris hypoplasia, aniridia, and microcornea, ectopia lentis. And coming to the Axenfeld-Rieger syndrome, anomalous development of neural test-derived anterior segment structures. So the main cause is this. And in Axenfeld anomaly, posterior embryotoxin, which you can see on the periphery, and with adherent iris stand. And in Rieger's anomaly and Axenfeld, anomaly plus iris hyperplasia. So Rieger's syndrome, Rieger's anomaly plus developmental defect of teeth and facial hyperplasia, pituitary abnormalities, etc. And Axenfeld-Rieger syndrome. So it is an autosomal dominant inheritance. It's usually bilateral. 50% are associated with glaucoma in middle or late age. And again here, the differential diagnosis of Axenfeld-Rieger syndromes, they can be ICE syndrome, aniridia, Peters anomaly, etc. And Peters anomaly, it's a developmental condition with an annular central opacity, which can be seen in this picture. And the opacity is adherent with iris stance. So a corneolenticular adhesion is seen, and usually it's sporadic. And aniridia, we can see in these two pictures. So it's a pan-ocular bilateral congenital disorder characterized by iris hyperplasia, and mostly it's autosomal dominant inheritance. And other ocular anomalies which are associated are microcornea, anterior pora cataracts, optic nerve, and foveal hyperplasia. There can be pendular nystagmus, and elevated IOP and glaucoma occurs in second decade or later, occasionally associated with congenital glaucoma. And also it can be associated with systemic anomalies, which are known as Wagner syndrome, and there can be Wills tumor in this. And Storrs-Weber syndrome is the other phacomatoses characterized by ipsilateral facial cutaneous hemangioma, which we can see in this picture, where the child has this port wine stain. It's also called port wine stain, and it's usually unilateral, but rarely bilateral, and there's no inheritance pattern. Glaucoma occurs in 70% in infants due to congenital angle dysgenesis, but after the first decade of life, the pathogenesis is elevated episcleral venous pressure. So features of glaucoma associated with non-acquired systemic diseases or syndromes, there can be like Down syndrome, can be Marfan syndrome, Well-Marchesani syndrome, homocystinuria, neurofibromatosis 1, Storrs-Weber, and many others like congenital rubella. And glaucoma associated with acquired condition. So again, it meets glaucoma definition, and acquired condition is recognized. Uveitis, steroid-induced trauma, for example, hyphema angle recession. Tumors can be benign or malignant, and retinopathy, ROP, and prior ocular surgery other than this. Open angle glaucoma or angle closure glaucoma is the mechanism. It's the type of glaucoma that can be associated. And glaucoma following cataract surgery. So we see lots of children with coming to us after cataract surgery, and usually it meets glaucoma definition only after cataract surgery is performed. And this can be subdivided into 3 categories: congenital idiopathic cataract, congenital cataract associated with ocular anomalies, or systemic disease with no previous ocular diseases. And based on gonioscopy, it can be open angle or angle closure. And in following cataract surgery, glaucoma can occur in up to 50%, and it's predominantly open angle. Risk factors are when the cataract is done in first year of life, especially within 6 weeks life, if there are post-op complications, and if the child has smaller corneal diameter. And likely mechanism is congenital anomalies of the outflow pathway, surgically induced inflammation, and altered intraocular anatomy post-operatively. So children who had undergone a congenital cataract, they require a lifelong follow-up so that we don't miss glaucoma, which we are aware that it is about 50%. And so evaluation of these children, when we suspect that, okay, there may be glaucoma in them, so we always need to evaluate under anesthesia, and we need to have their necessary, measurements taken. So this photograph shows how organized, the cart has to be, so that the time taken for anesthesia should be minimized, as there is so much hazard from the chemicals that we are using for the anesthesia. And the supplies we need to examine for anesthesia are, first we need to have a checklist, and then topical medicines, tonometer, then we need a scan, B scan, direct ophthalmoscope, we need tono pen or Perkins tonometer, portable fundus camera if we have, and indirect ophthalmoscope, and also retinoscopy and lenses for refraction, because sometimes the children are not cooperative in OPD. So evaluation under anesthesia, anterior segment examination, we measure the corneal diameter, look for corneal edema, check if the child has HAPS striae, then look at anterior segment anomalies like aniridia and others. And then we do the tonometry, then optic nerve and fundus evaluation, then finally we do the axial length measurement. So in children, it is very, very important to record the corneal diameter and the axial length, as sometimes IOP may not be accurate when under anesthesia. So coming to medical management, primarily used in pediatric glaucoma before surgery. So the definitive treatment for children is surgery, but sometimes we have to wait for them to be fit for general anesthesia. Then we give the medicine so that the cornea clears and the glaucoma progression is less. And also in the OT, the visualization is good. So juvenile open angle glaucoma, inflammatory glaucoma, and glaucoma following cataract surgery and other secondary glaucomas also are started with medical management, and needed, they undergo surgery. First line agent in children is topical beta blockers, topical carbamide anhydrase inhibitors, and prostaglandin analogs. And avoid alpha agonist because of CNS side effects like apnea, hypotension, bradycardia. Topical beta blockers cause bronchospasm, bradycardia, and hypotension. So it should be avoided in children. Surgery, congenital glaucoma, surgery is the preferred definitive treatment. Angle surgeries like goniotomy, if we have a clear cornea, and ab external trabeculotomy are the procedures of choice. So high success rate in children diagnosed between 3 to 12 months, and trabeculotomy surgery are reversed for refractory cases. And in case of secondary glaucoma, angle surgery has low success, and we do trabeculotomy or tube. So angle surgery, for goniotomy, we need a clear cornea. And for ab external, Slem's canal is cannulated, as we can see on the picture. And trabecular meshwork is opened by breaking through Slem's canal into the anterior chamber. The surgeon should be cautious not to cause any false passages into the suprachoroidal space. So follow-up after for pediatric glaucoma is lifelong. We need to monitor IOP, monitor potential complications from prior surgeries, treatment of refractive errors, amblyopia, strabismus, cataract, and corneal pathology is a must. And we should always refer them to pediatrician and for genetic counselors. Now, before going to the discussion, I'd like to continue with chapter 12, that is medical management of glaucoma and ocular hypertension. So here the goals of treatment, medical management, is to preserve visual function by lowering IOP, and we should choose the regime with fewest adverse effects and the least disruption to the patient's life, and also the cost. So coming to the efficacy of treatment, it is judged by the following. One is the stability of the visual field, optic nerve head damage, and adequate IOP reduction. So we always have a target pressure. So the target pressure should be individualized for each eye. It depends, how high the IOP is at presentation when we first meet for the patient, and how severe the patient's visual field is. So all these factors lead us to how to target the pressure of our patient. So the disease progression, despite of lowering IOP, below target level is also a question. And so we decide whether medically or surgically we want to achieve the IOP, targeted IOP. And estimating target pressure, there are various points listed in this table. So number one is the initial target pressure. I don't want to go into details. And number two is risk factors that may necessitate downward adjustment of the target pressure. And third is factors that may allow upward adjustment of the target pressure, like decreased life expectancy or other comorbidities, prior history of stable or slow progressive damage, and high central corneal thickness. In such cases, we may have a higher target, like we may not want to have like single digits of the IOP. Maybe we are good with double digits. And coming to the ocular hypotensive agents, they are classified into different types. One is prostaglandin analog. Number two is adrenergic drugs. Number three is carbonic anhydrase inhibitors. Again, they are divided in topical and systemic forms. Then we have RHO kinase inhibitors. We have combination medications, and finally the hyperosmotic agents, which are mainly for emergency conditions. So this table, it shows the anti-glaucoma medicine, and here we can see the side effects and the IOP reduction and mechanism action. So I don't want to go into detail with this. Just to keep in mind, like in children, we want to avoid like drugs like alpha-GAN, and in pregnant women we want to avoid certain drugs, and also like in uveitis, sometimes we want to avoid prostaglandin analogs for the risk of like latanoprost for the risk of developing uveitis. And so again here the table is again here we can see like the different. And here in this picture, what we can see figure. So this usually happens with the prostaglandin analog. So in the left eye, the person has used latanoprost, so we can see thick long lashes. And also in the last two pictures, so in picture A, it's a normal eye, but in picture B, it is the eye of the same patient where the patient had got unilateral treatment of glaucoma with prostaglandin. And here again we see periorbital hyperpigmentations, and we can see hypertrichosis and deepening of the deepening of the superior eyelid sulcus. So this is because there is loss of periorbital fat. So these are few complications that can happen with anti-glaucoma drugs. And also in this picture we can see contact blepharodermatitis. So there are other many side effects, So it depends on when we use the medicine, like it depends which drug gives side effect to which patients. Like there can be simple side effects like punctate epithelial keratitis to dermatitis to deepening of the sulcus. So sometime after cessation of the drug, these symptoms will revise. And the combined medication, it improves convenience and patient adherence, and efficacy of fixed combination formulas is similar to that of each of the components instilled separately. Ocular adverse effects are the same as for both drugs given individually. And now coming to the general approach to medical treatment. So hypotensive therapy is individualized according to the need of the patient. So by establishing a target IOP, effectiveness of the therapy. So determined by careful, repeated examination of the optic nerve head, retinal nerve fiber layer, and visual field defect. And therapy for acute intraocular pressure. So when we have sudden rise of sudden elevation of the IOP, there is a need of immediate IOP reduction, which is required to prevent damage to optic nerve head, to clear the cornea, In this case, hyperosmotic agents and systemic carbonic anhydrase inhibitors are required. And severely elevated IOP may cause collapse of the Slem's canal. So these medicines are required. And use of glaucoma medications during pregnancy or by breastfeeding mothers, we have to be very cautious, when we are prescribing medicine to women or young ladies. So we should always ask them about whether they are pregnant or whether they're breastfeeding, because some of the anti-glaucoma medications are harmful to the fetus and also to the breastfeeding child. Normally, IOP decreases during pregnancy. So there may be underlying glaucoma, so if patient has some symptom, then only they will come for checkup. And there are limited studies are done in pregnant women or breastfeeding mothers. And also we advise them to do nasal occlusion while installing the eye drop. For them, a laser trabeculoplasty or surgical intervention is also required at times, and timolol can be used safely. And we avoid while doing surgery, we avoid mitomycin or 5-fluorouracil in risk of teratogenic effect if the mother is pregnant. Thank you very much.